right, so for those of you who do not know me, my name is Julia, and I am a genetic counselor in the Greenville office. I was chosen to give this seminar this month, and I asked my dad, who is a practicing cardiologist in South Florida, if he would give it for me. As a birthday present, he said that he would. So I actually learned a lot about my dad reading his CV that I did not know. But some of the stuff that I did know, he graduated medical school at New York Medical College in New York. He then went on to do his residency in Hartford, Connecticut, and he moved down to South Florida and Miami for his fellowship in cardiology. And he liked the weather so much that they decided to stay there and just moved a little bit further north in Fort Lauderdale, where he is currently practicing as a cardiologist. In 2015, he started a cardiac genetic clinic at his cardiology office, and he is currently running that. So he is going to talk about the diagnosis and treatment of cardiac genetic conditions. So I hope we all learned something today.
Thank you, Julia. Can everybody hear me okay? Stay away from that mic. Okay, thank you. And thanks for inviting me. I always like to be able to go where my children are and spend some time, so it's going to be a good week. This is much different than the last case presentation that you were just at. We're going to go from the microscopic level, the DNA level, all the way up to the 30,000 foot level. Okay, because this is adult cardiac conditions and how we try and make diagnosis and how they're treated for the most part. It's fairly fast-paced. There's a lot here. Julia has a slide set that's more complete than this that is in your G drive, I guess. So you can look it up at any time. If you have any questions, just interrupt. It's very informal. And if you notice any glaring errors in my genetics, please let me know. Because most of my literature here is cardiac literature, not genetics literature. Okay? So we're going to be talking about the cardiomyopathies first. Hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia, left ventricular non-compaction, and restricted cardiomyopathy. And this is what they look like. Arrhythmogenic right ventricular dysplasia affects the right ventricle, LV non-compaction. You get all of this weird malformed muscle here. Hypertrophic cardiomyopathy is very thick. Restrictive cardiomyopathy, this is really a neonatal disease and a child's disease. We don't see much of that. There's not much done about it. Dilated cardiomyopathy affects both chambers, as you see there. Excuse me, this is just one of two non-proprietary slides I had to sneak in. This is the genetics that are involved. You know them better than I do. I'm not going to belabor the genetics here. In general, this is what they tell us the yield is. For cardiomyopathies in general, these genetic tests are 30 to 50%. For isolated hypertrophic cardiomyopathies, 40 to 60%, although depending on the phenotype, it may be quite more robust than that. Familial dilated cardiomyopathy and arrhythmogenic right ventricular dysplasia. So I'd like to start things off and intersperse a little vignettes, and this is just from my little 3 or 4 year practice. A 47-year-old dance teacher with New York Heart Association Class 3 symptoms. I'll try and explain this stuff along the way for you, so if I don't, and I'm in my own alphabet soup, just interrupt. New York Heart Association Class 1, you can do anything, and it's fine. New York Heart Association Class 2, on moderate activity, you get exhausted. New York Heart Association Class 3, activities of daily living are starting to become a problem. The New York Heart Association 4, you can get out of bed and get to the bathroom, maybe. Okay, so she's a 47-year-old. She's about 5 foot, 90 pounds, dance teacher, and she couldn't teach her classes. She came in and on echocardiogram. She had hypertrophic obstructive cardiomyopathy, little variant of hypertrophic cardiomyopathy, in that the bulge is at the top of the septum and it blocks the blood flow out, much like an aortic stenosis does, but it's dynamic. It happens, it gets worse with exertion, it gets worse with adrenaline surges, and so on. The diagnosis is really corroborated by MRI And the septum is usually only about 10 millimeters, so 28 millimeters is pretty thick. Her blood pressure was 90/70 to begin with, as you would expect for almost any woman that size. Family history, there was nothing on the grandparents, but her father had sudden death in his 40s and nobody knew why. Okay, mother's alive and well in her 70s, 2 siblings, 2 sons, 4 nieces and nephews, and she tested positive for the NYH7 gene. Okay, so hypertrophic cardiomyopathy, 1 in 500, highly penetrant, most common structural cause of sudden death, particularly in young athletes. This is what you hear when somebody drops dead on a high school soccer field or football field, etc., especially when they're doing those 2 days. And I can get on my soapbox about the fact that in Europe they screen these cases much better than we do, including during competitive athletics at the high school level. You would be having an echocardiogram and an EKG. You don't do that here. You get a physical exam and maybe an EKG. That's battle to be fought elsewhere. So you can get it marked anywhere along the left ventricle. This is a normal left ventricle. This is an apical variant. Hypertrophic cardiomyopathy. My patient actually has thickening of the septum right here. That's where the bulge is. So every time the heart contracts, blood is blocked as it tries to go out. It generally is regional, although it can be global. It can be associated with arrhythmias and sudden death, shortness of breath with exertion, chest pain, like angina, can occur, palpitations, orthostasis, where their blood pressure falls, they can pass out, and they can have syncope or free syncope. Some ways to evaluate them. It's interesting about the chest pain syndrome. Just a little cardiac anatomy again. The coronary arteries fill in diastole. They're on the outside of the heart. The blood passively flows from the epicardium to the endocardium. So as the endocardium, which is supposed to be about, as I said, 10 millimeters thick, as it gets to be 20 or 30 millimeters thick, there's a lot more diffusion that has to take place. So you can get true angina, especially if the pressure inside the left ventricle, which is supposed to be from 0 to 5 millimeters of mercury, is up around 20 or 30 millimeters of mercury. If that's a back pressure against the diffusion pressure coming from the epicardium to the endocardium, you get true angina, relative lack of blood flow. And that's the mechanism for that. Okay, you can generally see an abnormal EKG with LVH type voltage. Cardiac MRI is a good way to evaluate this. And as usual, I have my anecdotes. I had a gentleman who was 360 pounds who had a thick left ventricle that looked to be concentric, all around the same. He was hypertensive. He was morbidly obese. He didn't have any coronary disease. But one day he walked into my office nearly pre-syncope and was having a non-sustained ventricular tachycardia. And lo and behold, but in his work, we wound up doing finally an MRI on him, and he was so morbidly obese we could not see the extent of his condition, and he truly had hypertrophic cardiomyopathy that was picked up on MRI that you couldn't see on echo because he was just too big. Then actin and myosin are affected. When you look this up at the microscope, they're all disarrayed for the most part. These are the major genes associated with it. You got to know much more about this than me. And those are the percentages of disease. Most commonly autosomal dominant. And if you ever have to answer any question about anything cardiac, genetic on a test, autosomal dominant. 85% of the time you'll be right. Okay. So pathologic variance we picked up in 40 to 60%, but we have a grading scale here, and depending on how young there is an onset, how thick the wall is, what the family history is, if there's been sudden death, if there's a reverse curve. And the reverse curve is a thickness more at the apex than at the top of the septum. Then the yield for genetic testing goes up. We try to rate these people, and we examine them yearly in addition to trying to get their families evaluated. A family history of sudden death, hypotension on treadmill testing. They all do a treadmill test once a year. Non-sustained ventricular tachycardia, event monitoring. Event monitoring is either 2 or 4 weeks, 24-hour monitor isn't good enough. And ventricular tachycardia is 3 PVCs in a row. That's all it is. Okay? And that's enough. 3-centimeter wall thickness, unexplained syncope. Any of those variations, ICD is recommended. Internal cardioverter defibrillator. Because those people are likely to wind up with ventricular fibrillation, and they're likely to be saved from that. So you can see an overlap with non-compaction in a certain number of cases, and there's a family history of sudden cardiac death that raises the stakes highly. My patient, if you remember, had the NYH7 gene, and that is a more severe type. But this is a weird disease, and there was actually an article in the Journal of American College of Cardiology last month which said that we're probably on the wrong path with this, because the endophenotypes are so variable that to think that it's a one-gene disease is probably not correct. Okay. So my patient has the worst variant, but I have patients that will make this diagnosis in their 60s, 70s, and 80s, and they've lived their whole life, and they've never had a problem until that age for other reasons. Okay. So it's a very weird disease. You can die very young. You can live into your 80s and 90s, and you may not have very bad symptoms. This variant is probably the one that has the later onset of disease. There's minor hypertrophy in variant. And if you have obviously, you all know, if you have more than one variant, you're in the worst shape. There could be overlap, and when we do panel testing for hypertrophic cardiomyopathy, we pick up a certain percentage of infiltrative diseases and glycogen storage diseases like Graves' disease. And also, in adults especially, amyloid, that's important because there are different treatments. Even with amyloid now, we used to think it was hopeless, but we're coming up with different treatments for amyloid too. So these are the other, you can have variants of hypertrophic cardiomyopathy with full Parkinson White. Full Parkinson White is an accessory pathway that goes on the outside of the heart to electrically connect the upper and lower chambers and has its own problems related to sudden death. Glycogen storage disease, statin disease, mitochondrial disease, syndrome, previous ataxia. Other phenotypes that might look like this on the cardiac disease involved to dilated cardiomyopathy and fatty acid oxidation disorders can also present this way. So how do you treat these people? Is there any good treatment for them? Beta blockers. Beta blockers are kind of anti-adrenaline drugs. They're negative. They slow the heart down and they decrease the vigorousness of contraction. And 2/3 of the heart cycle is actually relaxation. Only 1/3 is contraction. And of the 2/3 in relaxation, 1 is passive from your elastic fibers, like when you take a deep breath in and you just exhale, that's mostly passive elastic fibers. And the other 1/3 is active relaxation. This is one of the few conditions where we combine beta blockers with non-dihydrofuran calcium channel blockers like diltiazem and verapamil. We're just knocking down the force of their contraction. Also, disulfiramide, which is an old antiarrhythmic that didn't find much use because it really for people is not their pump function down. Turns out it's very good in this condition. And I have many people who progress from beta blockers. They go from being symptomatic to asymptomatic. It lasts a while. Then you put them on diltiazem or verapamil, and they get symptomatic, and then you add disulfiramide. Then you have to figure out what else to do for them after that. Thymectomy is where they actually go in and they take the muscle out. Okay, they shave the muscle down. The problem with that very often is that there are electrical fibers in that muscle, and people want pacemaker or ventricular conduction away. For the obstructive type, like my patient had, they used to think we put a pacemaker in the right ventricle and we delayed the contraction of the upper septum. It would reduce the amount of obstruction, and maybe that would work. They put pacemakers in people for about a decade, and then they realized it wasn't really working, so they stopped doing that. And then for people who are old and sick, you can actually, if they have the right anatomy, go in with the catheter to the septum to an artery, and basically toxic alcohol, 100% alcohol, you ablate the septum, you create an infarct, kill the tissue, block the obstruction. Okay. So in my patient, she had one son who tested positive, and one of her brothers tested positive. They're undergoing family counseling at this point. I don't have follow-up on. My problem with her is that she was 90 pounds and her blood pressure was 90/70, and I couldn't put her on any medicine. Every time I put her on any medicine, her blood pressure dropped to 60 over a pound. She was passing out. So we sent it to one of the 6 probably experts in the country for cardiomyopathy. And he concurred that it was a weird case, but the only thing that she could do was implementing it. And she's actually 2 years out now and teaching again. Did very well. Congenital restrictive cardiomyopathy, I'm just going to mention this to pass it by. Basically, it's a transplant situation where there may be assist devices that elevate the poor child. Again, that's the situation where we have dilated atria, very thick ventricle. Another case study, second one, 40-year-old white male came to me with shortness of breath on exertion. The second one shows dilated cardiomyopathy with an ejection fraction of 40%. Normal ejection fractions are 50 to 65%. Okay? It appears to be global. That's important because if certain sections are not working, you think that they had an infarct, a heart attack, or something like that. And it's a diagnosis of exclusion. So if you didn't have coronary disease, we did a coronary CTA on him. You don't have to do frank angiograms on people anymore to affect that. On echo, we realized he didn't have any valvular disease, he didn't have any leaking or stuck valves, and on monitoring, he didn't have any arrhythmias. And that's important because many people that come to us today with dilated global hypokinesis of their left ventricle are due to the fact that they had a fast heart rhythm, a tachyarrhythmia, most commonly paroxysmal atrial fibrillation, that they haven't felt going on for hours and days and weeks and months, and that just wore the heart out. And that can be corrected in most cases. So in the family history, the grandmother died with CHF, of unknown cause in those days. The father carried the diagnosis of idiopathic dilated cardiomyopathy. His mother was alive and well, had paroxysmal supraventricular tachycardia prolapse. He has 2 siblings, and he had 2 sons. We got the dad, and we tested the dad, who was positive for PTN, and we tested my patient, who was also positive. Okay, and right now, him and his children are undergoing genetic counseling. And this is dilated cardiomyopathy here, the left ventricle, as well as the right ventricle, both are usually affected. It was an arbitrary definition related to members of the family that were affected, at least 2 closely related to them. We didn't know about the grandmother. In this case, an individual dilated cardiomyopathy unexplained sudden death, age less than 35 is another criteria. 20 to 35% of people with idiopathic dilated cardiomyopathy, they have a familial form. And it increases up to 48% if left ventricular enlargement is an early sign, which it wasn't. The prevalence is 1 in 2,500. Still, patients of both ventricles can occur. It's predominantly the left ventricle that starts with. It's the most common cause of heart failure and arrhythmia in these people. About 20 to 50% of it, as I said, can be familial. Predominantly autosomal dominant, although you see all these other genetic forms, you know, there's a bunch of genes that can be affected that can cause this. And the TTN mutation accounts for 20% of the technical variants, with the LMNA about 6% or more. 5% of 2 or more pathogenic variants. And it can also be seen in, now these are the conditions that you all see here. Muscular dystrophy. Actually had a woman that I followed to 63 that had muscular dystrophy, finally succumbed to heart disease. Did not, and we didn't encourage her, did not want a defibrillator placed as her heart got worse. And did have a pacemaker if conduction system disease. Myotonic dystrophy, myofibrillar dystrophy, limb-girdle muscular dystrophy, hemorrhagitis, desmond-related myopathies. So how do you treat dilated cardiomyopathy? This is going to be a broken record because unlike oncology, we haven't gotten sophisticated enough to look for enzymatic or genetic targets at this point. And we treat them pretty generically. So what's the rationale for beta blockers, ACE inhibitors, angiotensin-converting enzyme, lisinopril, enalapril, things like that, ARBs, losartan, and so on, sacubitril, valsartan, combination drug with neprilysin, receptor inhibitors, decreases natriuretic peptide level, promotes diuresis, Spironolactone or aldactone, which antagonizes methylpeptide peptide, and other standard diuretics. Plus, if they get bad enough, their injection pressure falls lower than ICD and what's called resynchronization therapy. So what's been shown over and over again is that the pump can be preserved by an increase in the amount of work it does. And the simplistic way of thinking of it is that if the normal blood pressure is 120/80, and you reduce that blood pressure to 100/60, let's say, you're decreasing the work of the heart by 20 real millimeters of mercury every beat. The heart beats 100,000 times a day. Okay, and there's some various theories that we have about 2 billion beats in our heart. So the beta blocker decreases the rate. It also helps decrease the blood pressure. The ACE and the ARB decrease the blood pressure. You try these first and then go to this next. If that doesn't work, they also decrease the blood pressure. But fluid accumulation, because all the kidneys know is that they're not seeing the pressure head that they're normally used to seeing, so they're going to retain salt and water. So all of these derangements of metabolism occur that we try and antagonize. When the pump function is bad enough, under 35%, we usually recommend the defibrillator replaced because the risk of sudden death is higher. Now, we have no good ways of determining who should have a defibrillator and who shouldn't have a defibrillator. It's pretty generic at this point, and there are many studies ongoing to see if we can make it better than what it is now. Probably ischemic or myocardial infarction-related heart disease deserves a defibrillator more than a dilated cardiomyopathy at this rate. But basically, we replace 10 defibrillators to save 2 lives. And a defibrillator costs probably about 60 grand. So somewhere in the future, we're going to have to figure out a better way of doing things. Non-compaction, as I told you in the slide here, it's this weird condition here. It's been all the rage in cardiology over the last 30 years. It was newly discovered, and as usual, people went wild over it. It's 12 to 15% genetic. Autosomal dominant greater than excellent autosomal recessive. Field on genetic testing, maybe 40 to 50%, if you make the right diagnosis, and these are the genes that are involved in it. It has the same presentation as a dilated cardiomyopathy, shortness of breath on exertion, weakness, heart failure, swollen ankles, the whole bit. You can make the diagnosis on echo, but MRI and CTA are probably better. It's congenital maldevelopment of the muscle. It's symptomatic in presentation, more functional than arrhythmic, although it can be arrhythmic. And a mortality rate in children 1 to 17 is 14%. The treatment of sustained cardiomyopathy, beta blockers, ACE inhibitors, ARBs, et cetera, et cetera, et cetera. Nothing glamorous there. Ventricular cardiomyopathy with right ventricular cardiomyopathy with dysplasia. This straddles the spectrum from what we call cardiomyopathies. I don't think I have to go back to this picture here. This is arrhythmogenic right ventricular dysplasia. The right ventricle enlarges, the left ventricle is usually normal, but it can involve the left ventricle also. And it straddles between the cardiomyopathies and what we call the channelopathies, the arrhythmia-producing things, long QT syndrome, etc. The prevalence is supposed to be 1 in 2,000, 1 in 1,000 to 2,500. It involves intracellular junctions, mainly caused by myocyte death and replacement, generally presents in the 2nd to 5th decades of life, and characterized by ventricular tachycardia and sudden death in young individuals and athletes. Is that better? Is that any better? Okay, so 40% may be asymptomatic. It presents with consequences of the arrhythmia as opposed to a cardiomyopathy. Palpitation is fainting or near fainting, and they can get near atypical chest pains. They have sustained and non-sustained ventricular tachycardia with the left bundle branch pattern. So, there's a right bundle branch and a left bundle branch in the heart. And anything that comes from the right side of the heart is generally present with the left bundle. So if you get a PVC, preventricular contraction. And it comes from the right side of the heart. It'll look like it has a left bundle branch block. Likewise, it comes from the right side of the heart. From the left side of the heart, the PVC will look like it has a right bundle branch block. So none of this stuff is inscrutable, and knowing what to look for is important. Unfortunately, sudden cardiac death could be the first presentation. There can be left ventricular involvement, and really, MRI is a better way to make the diagnosis, although you can hint at it on CTA and echo. And why? Because MRI gives you more tissue characteristics than CTA would give you. And this is all tissue characteristics. Do genetic testing in them. They're not allowed in competitive athletics. Gene positive and phenotype negative, no treatment. Not sustained ventricular tachycardia, sustained ventricular tachycardia, PVCs burden greater than 15%, only beta blockers. Sudden cardiac death or sustained VT, beta blockers plus an ICD, and undetermined syncope, they go to electrophysiology testing. Usually one with a beta blocker has to be if they're induced into ventricular tachycardia. Now we're going to hit the channelopathies. Long QT syndrome, short QT, catecholaminergic, polymorphic ventricular tachycardia, Lugano syndrome, which I heard somebody talking about earlier. I guess there's a family around here with that. Arrhythmogenic respiratory dysplasia, which we just covered. So these involve the sodium channel in the cell membrane. The genes that involve the membrane directly have a worse prognosis than the genes that involve the cell membrane apparatus for the most part. These are the genes associated with that. Again, long QT has a high yield for genetic testing. Lugano, not so much. CPVT, about 45 to 60%. Short QT is a waste of time. We don't really do that. Long QT syndrome, 1 in 2,000 to 5,000 people. Looks like this. Although you can get long QT3, looks the same except it's flat here. Okay? That's the normal QT interval. That's the long QT interval. Okay? Variable age of onset. The presentation ranges from fainting to sudden death. Lifelong asymptomatic state can happen, or you can have death in infancy. 10 to 40% of patients with long QT syndrome have a normal corrected QT interval on their EKG. Males are more likely to express the disease before puberty, women after, and transient nature on the EKG, so that's a problem. High-risk situations, the personal history of cardiac events, particularly occurring while on therapy, is important. Women with long QT have to be watched, especially in their second year, in their first year after giving birth. And male children with long QT1 are particularly at risk for sudden death. But long QTS3 is associated with higher mortality and death rate than either one of those. There are 17 genes that are linked with long QT syndrome, and they're most commonly inherited from one parent. The detection rate is 70-75% for the sequencing of the 3 most common genes. These are the 3 most common genes. They account for 95% of long QT syndrome. Okay? So the other 14 genes account for less than 5%. This is what we deal with most of the time. Those are the triggers. So long QT, you're activity-based. And this is sometimes where I remember that I had this one not so great anecdote of a young high school student, junior, who was a track star, who was getting scholarships to college, who had ADHD, and was now, when he was getting to at the end of his race, he was passing out. He passed out twice. Paramedics had gotten there, and by the time they had gotten there, he was fine. He came to see me, and as it turned out, his ADHD drugs were causing long QT syndrome. So we took him off his ADHD drugs. His father brought him to Hopkins. He brought him everywhere to make sure that there was nothing else going on. So we took him off his ADHD drugs. He started to do poorly in school. He lost his scholarship to college. And it's really kind of, he couldn't take the drugs anyway because they could be lethal. So he's still alive. He works for his father at this point, who, thank God, was independently wealthy. But he never was a track star, never went to college because of that. Long QT genetics, as I said, the last four genes, last 4 genes account for less than 5%. This Aneurysm real was called long QT7, nativity syndrome was long QT8. This is probably one of the most important things you can get from long QT. To go to this website, when you're going to put people on drugs, find out if their drugs prolong their QT intervals. What drugs prolong QT intervals? Most antihistamines, a fair amount of antibiotics, including erythromycin-based antibiotics and levaquin and Cipro and so on, the quinolones, all prolong QT intervals. So there's a lot of stuff we use on a regular basis that prolongs QT intervals. Not only should they be used in these people, some people are saying they shouldn't be used in anybody at this point. So if they have sudden cardiac events, they get ICDs and beta blockers, and they can remain active, they can do a stress test and not induce ventricular tachycardia. Long QT syndrome is simply beta blocker, and they prefer nabilol or propranolol. I mean, we tend to use a lot of atenolol, metoprolol, and carvedilol in cardiology. Propranolol and nabilol are lipophilic, so it's thought that they get into the lipid membrane, and that's the mechanism by which they decrease sudden arrhythmias and sudden death for a lot of people. So the EP doctors, the electrophysiologists, tend to use more nabilol or propranolol than the general cardiologists do. Okay, so the treatment of recurrent arrhythmias is ICD. If they're refractory to ICD treatment, behind the seventh cervical vertebra is the sympathectomy. That will help sometimes too. If they're asymptomatic and their QTC is less than 470, nothing versus a beta blocker. Most people will put them on beta blocker. If they're between 470 and 550, they get a beta blocker. If they're greater than 550, they get an ICD. If they're post-puberty female, greater than 500, they get an ICD. There's a sudden death panel now for infants, and about 16% of SIDS deaths are thought to be due to these arrhythmic mechanisms. Also, I forgot to mention with dilated cardiomyopathies, there's something called peripartum cardiomyopathy, and most women who develop peripartum cardiomyopathy now should probably be genetically tested for familial variants of dilated idiopathic cardiomyopathy. So, for long QT syndrome, and this is what I think somebody was talking about, who got us, even when they came in here today, ICD is never indicated solely based family history of long QT syndrome. They really need to be evaluated. Short QT syndrome is really kind of a morass. Nobody really knows what to do with this. There's a lot of genes associated with it. There's an autosomal dominant inheritance. They have a structurally normal heart. Many are asymptomatic. They may have parasympathetic fibrillation, but they can have unexplained syncope and sudden death. There's QTCs less than 360. There's nothing diagnostic with family history or genetics. But the most important thing is to rule out secondary causes of short QT in terms of drugs and acidosis and hypercalcemia. I mean, usually when we go through this, people don't conclude wind up having short QT. They can have an EPS evaluation, and if they're inducible, they can get an ICD. If they still start having ventricular tachycardia, we use another old antiarrhythmic called quinidine. The only time I've used quinidine actually was quinidine. Quinidine is racemic mixtures are mirror images of molecules, right? And quinidine looks like quinine. So only time I used quinidine previously was an 18-year-old kid that came back from Africa with the chief complaint of malaria, and he did falciparum, and we treated him with intravenous quinidine. That's the extent I used. Catecholaminergic polymorphic tachycardia, CPVT. Basically, it's a childhood disease seen from 7 to 9 years old, diagnosed by EKG. When you exercise people on a treadmill, they have PVCs, PACs, or they have runs of couplets or triplets, 2 or 3 of these in a row. generally in healthy, normal people, they go away with exercise. They're what we call overdrive suppressed. When you start seeing more and more activity with exercise, that's not normal. And if it's my usual adult, they probably have a clogged coronary artery causing ischemia, causing immobility. But in a 7 to 9-year-old, the CPVT, okay, 30% of patients have a family history, and they have sudden death under the age of 40. There are 7 genes known to be associated with it. 45 to 60% of affected patients have the detectable variant. It's autosomal dominant more than autosomal recessive. RYR2 accounts for over half of the cases. Mean penetrance is 83%. Males have 4 times the increase of event rates as females, and there is no data to support using genotype and risk stratification. CPVT can be familial or sporadic, onset in childhood, prevents the ventricular tachycardia, fibrillation, or sudden death. Diagnosed with a stress test. And the non-selective beta blockers, as I told you, propranolol and nalgene are used. And we actually recommend that they have an AED. The family actually buys an AED and travels with it for their child. Persistent DT, in addition to beta blockers, you can add an ICD. Flecainide is sometimes working, which is an antiarrhythmic, or verapamil, which we talked about before. And for refractory cases, as I said, you can go behind C7, take out the stellate ganglion, and that really settles things down. It's sort of, they think that there's a catechol surge that comes there. It's sort of like, I guess, akin to, which some of you people may know about, the ketogenic diet that they recommend for some kids with refractory seizures. That's kind of like what doing a sympathectomy and all of these arrhythmias is like for us. We just think of catechol storm. And helps out tremendous amount. Lugano syndrome, characteristic EKG here. 1 in 10,000 presents with cyclical episodes between 7 and 12. 80% may experience one cyclical episode. Sudden death maybe up to 30%. The resting EKG may be completely normal, but their exercise stress test will usually induce something. A significant number of cases may be sporadic. It tends to be autosomal dominant with reduced penetration. 14 major genes associated with it. Most significant variants are SCNA5A gene, and the phenotype can overlap with long QT syndrome. Lugano syndrome illustrates the nightmare of genetic testing. 60% are phenotype positive and genotype negative. Only 50% penetrance may have 22 or 23 genes associated with it. It is all by phenotype and Heart Rhythm Society scoring system. That's another thing I'll get on my soapbox about. In Europe, genetic testing, as you all know, is just taken for granted. You can do it on anybody. And here, there's no major cardiac society other than the Heart Rhythm Society that recommends genetic testing, and they do for long QT and hypertrophic obstructive cardiomyopathy. Those are the only two at the present time. And getting genetic testing proof is tough, as you know. So Lugano syndrome, sudden cardiac death, they get an ICD plus or minus amiodarone. Amiodarone is a very powerful antiarrhythmic that has long-term consequences that we don't like to use in sensitive people over 75. Quinidine, which you've heard about before. Asymptomatic Lugano type 1, no treatment. Asymptomatic Lugano type 1, drug-induced, no treatment. So they found out in the lab, if you gave a certain number of people who thought had Lugano, the normal EKG flecainide, it brings out that weird EKG pattern. But then they realized they didn't know what to do with it, and it didn't really help them very much. Asymptomatic Lugano type 1, DPS, inducible DT, and 6 they get an ICD. Okay. So this is the various yields on channelopathies. 60% for CPVT, 75% for long QT. Lugano type 1 is something I think we should test, none of the others. Now I'm going to switch to genetics of inheritable disorders of connective tissue. I put this whole list up there. You guys know this better than me. And this is a segue to use it to talk about thoracic aortic aneurysm and dissection. Okay. Untreated thoracic aortic aneurysm and dissection have a high morbidity and mortality. We know that. They're usually dead in minutes to seconds. 2014, nearly 10,000 deaths were associated with aortic thoracic aneurysms, and 17,000 deaths in 2009. 20% of people with thoracic aortic aneurysm dissection have a genetic predisposition. It's genetically heterogeneous with 20 genes or more associated with it. It can be isolated or syndromic. If you know, isolated forms may be associated with congenital heart abnormalities. In addition, little hernia, scoliosis, ocular abnormality. You know the syndrome, Marfan, Louis Dietz, Brexton, go over how to do in that presentation. Okay. Some forms are associated with reduced penetrance. The age and presentation are highly variable. Other fun facts: 12% will have abdominal aneurysms, 9 to 14% will have cerebral aneurysms, 5% will have ileal or popliteal aneurysms. Other features: high incidence of patent ductus arteriosus, a bad gene, bicuspid aortic valve, libido reticularis, and occlusive vascular disease. Ascending dilatation of the aorta with congenital heart disease is well recognized in all of these conditions. Marfan, Turner's, bicuspid aortic valve, coarctation of the aorta, tetralogy of below. Possible cardiovascular complications overlap to a large extent between Marfan's and thoracic aortic aneurysm with dissection. With aneurysm, dissection, and rupture, tortuosity, and stenosis, and microvalve prolapse with patent ductus arteriosus. Much more benign. The diagnosis, as you know, should be normalized the body surface area with a Z-score. If not, use a basic size of 4 centimeters in an adult. It can be detected by echo and esophageal echo. But CT in adults, MRI in children are the better way to make these diagnoses. You know, again, better than I do, Louis Dietz and Marfan's and the scoring scale for Marfan's to be alert. And the FBN1 gene in Marfan's has a very high preponderance. But even in thoracic aortic aneurysm with dissection, you can still pick it up in 52% of the cases. So be alert for that. Marfan's prevalence 2 to 3 per 10,000, 25% may be new mutations. Constant aortic monitoring is necessary. Prophylactic surgery should occur in 4.5 to 5 centimeters. The medical treatment should include beta blockers and losartan. There's autosomal dominance with FBN1 gene mutation, affects the structural integrity and weakens the matrix of connective tissues and enhances the activity of metalloproteases, breakdown tissue also. Abnormalities of cardiovascular, skeletal, and ocular system are prevalent. Beta blockers, I already told you the value of beta blockers in decreasing. When it comes to aortic problems, what you want to do is decrease the shearing forces. So beta blockers decrease the force of a contraction. We give beta blockers symptomatically for people that have PVCs. You really shouldn't be treating them unless it's driving the patient crazy. And I tell them all, I said, I'm going to give you this medicine called a beta blocker. You're not going to have any less PVCs. You're just not going to feel them as much. And that's exactly what happens. So the beta blocker decreases the shearing force on the aorta, and the ACE inhibitors of the ARB decrease the pressure that's produced. So there's less stretch is what we're thinking here. It's extremely important to keep their systolic pressure less than 120 lifelong and less than 110 after they've had an event. As you know, as you get dilatation of the aorta valve may not fit. So you can get aortic insufficiency. Of course, the dilatation is aneurysm. The aneurysm can dissect or rupture. Strenuous activity is avoided in these children and adults. Interestingly, when you look at the literature, beta blockers are of proven benefits, but ACE and ARBs will start to lose a benefit in mouse models, but we still use it with something else. They have concomitant atherosclerosis, and there's no reason why they can't, because they're adults. We use statins. But this was interesting. Calcium channel blockers may have adverse effects that should be used in caution. One study with Morgan syndrome showed to accelerate dilatation. Certainly with things like amlodipine and diphenhidine and so on, the dihydropyridine calcium channel blockers used without beta blocker, they do accelerate heart rate and contractility, so that may be the mechanism for that. In general, adults with thoracic aortic aneurysm, you don't operate on them until they're over 55 millimeters. Bicuspid aortic valves without risk factors, 55 millimeters. Bicuspid aortic valves with risk factors, prior family history, certain family history, dissection, etc. Patients with Marfan's, actually Marfan's is between 45 to 50 millimeters. And Louis Dietz is actually the earliest. They're telling us between 4 and 4.5 millimeters. Most of these patients with Marfan's, Louis Dietz, etc., I sent to the geneticist at Memorial Healthcare System who follows them on a regular basis. The risk of rupture is markedly increased depending on size. Obviously, the bigger it is, the more likely it is to rupture. Corrective surgery is indicated and talked about. The aortic arch is difficult. The aneurysm may not just be at the level of the ascending aorta and the aortic valve. If it's between the aortic valve and the aortic arch, it's kind of easy. If it involves the valve, you have to do other things like replace the valve, reimplant the coronaries. If it extends to the arch, really tough because you've got all these major blood vessels coming off the aortic arch that go to the head, and so on. And the surgery for it is quite complicated. You actually, in addition to going on extracorporeal bypass, you have to turn the circulation off completely for 45 minutes. You literally put the table in a little bit of trendelenburg, pack the patient's head in ice, you do cerebral perfusion, and you turn the machine off and you work really fast. So it depends on the level of valve. This is what you have to do. This is an easy patch, although I would tell you nowadays, a lot of people would probably just stent this kind of a problem. This is the problem I was talking about, where it involves the arch, and sometimes the arch and branches, they can be aneurysmal too. Don't forget. The descending aorta is usually always stented. Descending thoracic aorta can be stented if it's distal to the arch, and that's the repair of choice. Now, changing again to bicuspid aortic valves. Bicuspid aortic valves are the most common congenital abnormality of great blood vessels in adults. First described by Leonardo da Vinci in 1513. This guy continues, the more you read about it, here he is just looking at anatomy for an artist's sake, and he notices that some people have 3 cusps and some people have 2 cusps. They're aortic valves. It's unbelievable. Ascending aortic dilatation is common, and we've known for the last decade or decade and a half that we should be testing all our bicuspid aortic valves for aortopathy. It was originally thought that the dilatation of the ascending aorta, bicuspid aortic valve, was due to the valve being askew and the fact that it created turbulence. We found out that's not true. It's a connective tissue disorder. I actually have a patient like this in my practice. A Ross procedure. A Ross procedure is when you get somebody who's young that has bicuspid aortic stenosis, which usually has to be fixed in the 4th or 5th decade of life, but maybe they're in their 30s now, and it's gone bad fast. Somebody came up with a surgeon came up with a brilliant idea of let's take out the pulmonic valve and pulmonic root, put that where the aorta is, and then just put a graft and an artificial valve in the pulmonary system, because the pulmonary system is low pressure, low flow. And whereas things may wear out in the arterial system in 10 or 20 years, maybe it'll last 20 or 30 years in the pulmonary system. So they did that. And I actually have a patient like this in my practice. The problem is that, as you know, about 11%, the same pathology that's present in the arterial wall of the aorta is present in the pulmonary artery, and these patients may get into trouble later from that also. Congenital bicuspid aortic valve is associated with coarctation of the aortic, ductus arteriosus, VSDs and ASDs. Some classifications distinguish between congenital and acquired. And there was a book just written in 2017 discussing aortopathy between somebody from Germany, a German surgeon, and somebody from Hopkins. And I was blown away to realize that there's a bunch of bicuspid aortic valves and aortopathies that occur as acquired conditions in utero from infections and other things. In general, means that they have two cusps and two sinuses. Acquired means they have two cusps and three sinuses. Probably most of the patients that I see as adults have two cusps and three sinuses. So they may have been born with a bicuspid aortic valve, but it was probably acquired in utero. There's aortic dilatation in 70% of these people. The phenotype can vary very widely. Environmental factors may play a role, as I just told you. There's a male preponderance. There's familial occurrence. This is what's really scary, which I learned in reading this book too, that if somebody has a bicuspid aortic valve and aortic dilatation, their siblings, I have a patient who has two brothers. Their siblings with tricuspid aortic valves have an increased occurrence of thoracic aortic aneurysms and need to be surveilled also. So I brought his brothers in and would scan their aortas, and their aortas are normal at this point, but they're in their 30s. That was a little bit disconcerting, but only a small amount actually have chromosomal disorders. In fact, congenital aortic valve may also be associated with anywhere from 1 to 5 weeks. There's 20 different syndromes that are associated by it, and Osler first described endocarditis with this condition. The prevalence is 0.5 to 1.39%. Prevalence of dissection 3.5 to 11.8%. It's polygenetic, frequently accompanied by aortopathy. Most common congenital heart lesion with a prevalence of 2%. Bicuspid valves have medial abnormalities, non-inflammatory smooth muscle cell loss, fragmentation of elastic fibers, accumulation of vascular ground substance, may involve the entire aorta. The dilatation begins in childhood regardless of stenosis. Same medial pathology, coarctation. Now we're going to switch gears again. Coarctation of the aorta has the same medial pathology on light microscopy as bicuspid aortic valve, often accompanied by bicuspid aortic valve. I have an anecdote about that too. About 30 years ago, a patient was sent to me from Michigan because he winters in Florida and told he had aortic stenosis and he needed to have his aortic valve done. But they hadn't done anything more than an echocardiogram on him. So in working him up, we found that he had a distal lesser Flavian coarctation of his aorta, and his aortic valve appeared only mild to moderate as far as stenosis goes. So we actually sent him to the interventional radiology who stented his coarct, which was symptomatic and probably causing his symptoms. And this gentleman just passed away at the age of 91, never needing an aortic valve done. The reasons to do something about the coarctation, 20 millimeter gradient across the upper limb, hypertension, pathologic blood pressure response to exercise. You can stroke out from that. There's the coarctation. Just look at the left subclavian. Okay. Most can be fixed by balloon dilatation and stenting. For those not amenable to that, you can do surgery on it. So what about genetic defects associated with thoracic aneurysm and dissection? We've talked about all these conditions before. You know them better than I do. When you start to get symptoms, what can happen? You can rupture your thoracic aorta to the left and the right side and tension in the thorax. You can rupture it most commonly into the second part of the duodenum and get an enteric fistula. You can rupture it into the inferior vena cava, or you can just rupture it intramurally. Anything that's proximal is a surgical emergency. Anything that's distal is medically when it comes to dissection. This is the most important thing. And now, in ERs, I don't know if you're aware, in ERs, people come in with chest pain now, we're doing a lot of CT angiograms on them. We inject them with dye, we look at their, some of them call it a triple rule out. They look to see if they had a pulmonary embolism, an aortic aneurysm or dissection, and they can actually see if they have coronary artery disease at the same time. So what's happening is that we're picking up with people with chest pain and they don't have coronary artery disease as the cause of it, they have a dilated aorta, you have to worry that something else is going on. They either have a penetrating ulcer, they have an aneurysm, or they have a dissection. Dissection is a rip or a tear, penetrating ulcer, and these things are awful. I've had a couple of people. The pain can radiate just like angina, although it tends to radiate more to your shoulder blades. It can radiate either arm to your jaw. These people are excruciating pain, swiveling around, which is not something you ever do with angina. Angina, usually you want to be quiet, everybody leave you alone. And these have to be watched carefully because they can bump to intramural hematoma or a full-fledged dissection. And all you do for them at that point is to slow them down with beta blockers, or put them on ACE inhibitors, and or nitroglycerin. The one thing you don't want to do is anticoagulate. Okay. The results of medial abnormalities, as I said, you can get all of these things that happen. In addition, it has problems with reduced coronary blood flow and left ventricular hypertrophy develop with thoracic or aneurysms. And I'm sure you're all going to sign a little bit of relief here. This is the last topic. Okay. This is genetics of hyperlipidemia. Homozygous hypercholesterolemia, 1 in a million. Familial state of hyperproteinemia, 1 in 5,000. Heterozygous familial hypercholesterolemia, 1 in 200 to 500, with very high incidence. Familial fatal hyperproteinemia and combined hyperlipidemia are the two things we see most commonly. So what are the genetics of them? Interestingly enough, the genetics of homozygous hypercholesterolemia is probably a misnomer because there's usually 2 of 3 genes involved. The LDL receptor, an apoprotein B, or the PCSK9 protein, okay? So it's not actually, it's 2 different genetic defects that add up to cause what we consider to be homozygous hypercholesterolemia, which is triglyceride greater, a total cholesterol greater than 500 with an LDL of 350 to 500. Triglycerides are usually normal. And in heterozygous hypercholesterolemia, it's just one of these defects. Either the LDL receptor isn't grabbing, it's defective and it's not grabbing the cholesterol out of your blood. There's an apoprotein B defect, so it's not hitting the receptor and being taken out of your blood. Or the PCSK9 protein is actually being overproduced and it binds with the LDL receptor and causes high LDL receptor turnover, and that takes less cholesterol out of the blood. So heterozygous hypercholesterolemia has one of these genes associated with it, and homozygous has two of these defects. In Europe, again, where they're allowed to do genetic testing and it's paid for, certainly Northern Europeans, they think this is a very underestimated condition. Patients less than 20 have an LDL greater than 190. Ages 20 to 29 greater than 220, 30 or older greater than 250 in general. The guidelines are to treat males with this condition down to age 10, and women after their last growth spurt, usually by 19, they're treated with statins as well as other medicines, cholesterol protein inhibitors, we'll talk about that. Perhaps even PCSK9 inhibitors. The women are told to take the medicine, plan their pregnancies, get off the medicine 3 months before, have their kids quickly as they can, and get back on the medicine. That's basically how that's treated. So, what is this? You have an elevated LDL. Men have a 50% risk of having a coronary event by age 50. Women have a 30% risk by age 60. By age 65 and 70, they're all caught up. Most commonly is inherited in a semi-dominant manner with a gene dosage effect. Familial hypercholesterolemia can be categorized into 3 subtypes: heterozygous, homozygous, and autosomal recessive for the most part. It's presented in the 5th and 6th decade of life. One pathologic variant in any one of these things we talked about can account for it. The more severe presentation is really rare. If you have 2 or more of these variants, you will wind up with a higher LDL and a higher risk of coronary disease. And these are the things you'll see. Plaques around the eyes, arcus senilis here. And, you look at that in men and women, with LDLs that high. You have tendinous xanthomas associated with this also. And actually, the International Foundation for Familial Hyperlipidemia thinks that everybody should be genetically tested if they have anything. They have an LDL of 190 per se. This mainstay of treatment are statins. Statins are cholesterol absorption inhibitors. They work at the most common point of cholesterol production at the rate-limiting step, which is why they're most effective. They can drop the cholesterol by 30 to 50%. They're graded in how well they work. Lovastatin, which was Mevacor, is the weakest. Then Simvastatin, and Bravastatin, and Atorvastatin, which is Lipitor. Crestor is Rosuvastatin. There's also another one called Atorvastatin that you can use. You can combine them with cholesterol absorption inhibitors, what ezetimibe is. But it's interesting. There's probably genetics that nobody knows about this, because there are some people who are hyperabsorbers, and you put them on ezetimibe and generally lower the cholesterol another 20% on top of the statin. Occasionally, you'll find somebody whose cholesterol goes down 50%. And more often than that, you find somebody that the ezetimibe doesn't really do anything for. So there are hyperabsorbers and underabsorbers that ezetimibe may or may not work for. Bile acid sequestration basically just bind to bile acids and cholesterol in the bowel. PCSK9 inhibitors are the newest and latest and greatest. They're biologics, they're injectables, they're antibodies. The PCSK9, which is a protein produced by the liver, which goes into the LDL receptor. It allows it, when it's endophagocytized, to be recycled. And by inhibiting PCSK9, it doesn't go into the LDL receptor. So the LDL receptors hang out on the liver for 30 to 50 to 100% longer. So you have more LDL receptors on the liver, grabbing more cholesterol. Obviously, if your other defect is an LDL receptor defect, that's not going to be as potent as a statin. So all of these things may be able to be used in conjunction in different patients, depending on what their defect is. That's it. I'm going to do a lot after, as I said, there's a more complete slide set for your private review. Does anybody have any questions about anything I said? They're all blown out now.
I have a very strange question. Hypercholesterolemia. I don't know which type this woman had, but friends of friends went on a vegan diet. Clinically, medical effects. Just the vegan diet.
So it wasn't genetic then. She's saying that her
I believe it was.
there are so what I do also is I run a cardiometabolic clinic, and the whole point of the cardiometabolic clinic is to teach people how to eat properly and exercise to lose weight, and then see what happens to their LDL and their triglycerides and their HDL and so on. What you find is that some people's bodies don't read the book. You wouldn't expect, seriously, there are some people that you wouldn't expect their LDL. You see somebody with an LDL of 190, you're saying to yourself, they have a genetic problem. They can do whatever they want with their diet, but they're going to need drug help. And I have people who say, I'm going on a vegan diet, and I'll see it in 6 months or a year. And maybe 1 in 10, I'll see a dramatic fall in their LDL. But most people not. Most people not. So my answer to you is you do see that. Most coronary disease is polygenetic. Okay? There's more than 20 genes probably involved with why you develop atherosclerosis. I have patients in my practice with astronomical cholesterols. I take care of a woman who's 60 or a woman who's 90. They don't form plaque. How do I know that? We've done what are called coronary calcium scores on them. They don't seem to have any plaque anywhere in their body. And then I have other people that walk in and they have LDLs. I have this one lady who was a vegetarian, not a vegan, 5'4", 110 pounds, athletic, played tennis, played golf, was getting exertional chest pain on tennis, playing tennis. Her LDL was 85. Her total cholesterol was 145. Her HDL was 110. She had been told by her primary doctor, you can't have any heart disease. Your numbers are too good. Needless to say, we put her on a treadmill, love distress test, and she has a stent in her case, the widower movement. Okay? And to this day, 7 years later, she keeps saying, why did this happen to me? I'm the poster girl for what you should have done, blah, 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 blah. So what haven't I told you? Her dad died at 37 of a massive heart attack. Her mom's 97. Her dad died at 37 of a massive heart attack. So she told me, you've got to get my brother in here. He's 5 years older than me. He's way overweight. He doesn't get off his butt to do anything. Bring him in. And we do a calcium score. And his total cholesterol, his LDL was 161, higher than her total cholesterol. Total cholesterol was like 230. His HDL was like 40. Triglycerides were a little out of whack too. He didn't have any plaque. So he kind of got the mom's genes. She kind of got the dad's genes. And it's never been explained to me. So it's a very humbling profession when you see stuff like this happening. So it's not what your cholesterol is; it's what your body does with it. And we have the technology nowadays to tell whether people are forming plaque or not, certainly over the age of 40. If they're diabetics, maybe even older, in their 30s. Yes? Yes. Oh, it's talking about postpartum cardiomyopathies. We see about one a year. I don't know how many deliveries we have in our hospital. It's the level 3 center, so we don't get any high risk of pregnancies for the most part. But we see about one a year. A woman, and it can happen at any time after multiple pregnancies or a single pregnancy. Usually it occurs within 6 months to a year. We usually see it within 6 weeks to 6 months. Their heart just blows up and enlarges. And we wind up having to treat them with all those drugs that you saw, beta blockers, and ACE inhibitors, diuretics, etc. But in the past, we never did any genetic testing on them, and we never asked them about a family history of dilated cardiomyopathies or heart failure or anything like that. So we started to do that now. I don't have any good cases to present because we haven't had any genetically positive at this point. But nobody really knows if that falls into the idiopathic. Idiopathic, we feel all the health, why it happens. So that falls into the idiopathic category, pericardial cardiomyopathy. They used to think that you should biopsy these people and they might respond to some forms of immune therapy right away. That's all been debunked. Treat them like any other idiopathic dilated cardiomyopathy. The good news is that a lot of them go back, 80% of them go back to normal on treatment. The bad news is that you can't stop the treatment. If you stop the treatment within 2 years, the cardiomyopathy comes back. And the other bad news is you tell them not to get pregnant again. So